Hello, everyone. It's really a big pleasure for me to be here today. And thank you again, Daniel, for sharing your story about your daughter, and also Mike and Megan. That's why we're here. That's the most important thing we want to talk about today, is how these stories like yours resonate with all of us and how we can use this energy to push the field forward. And Kim had asked me to give a little bit of background about the research and molecular classification of biomarkers and how that will hopefully guide us, or is about to guide us, in our treatment decisions going forward. So if you want to talk about progress, you always have to start in the past. So let me start with 1924, a long time ago. That's when ependymoma was first described by Professor Bailey. And so 100 years later now, you would think that there has been a lot of progress, which there has been, but not really until the last 10 to 15 years. So for about 80 years of knowing this diagnosis, there hasn't been a lot of progress. Why? Multiple reasons: neurosurgical, progress that needed to be made, pathology progress that needed to be made, oncology progress that needed to be made. But for the longest time, we really used to diagnose ependymoma under the microscope by seeing ependymal rosettes. This is what in 1924, Dr. Bailey had seen. And then classifying ependymomas by where they were from in the brain and spine. So either in the upper part of the brain, called supratentorial, in the lower part of the brain, called infratentorial, or in the spinal cord. And that was about the case everywhere around the world until about 10 to 15 years ago, when the first few groups started finding the drivers, or the first of many drivers known to underlie ependymoma. And these few groups found something that's called a fusion. That's a complicated DNA event, something in the nucleus of those cells. And it was dramatic in the way it changed the field, because for the first time, we kind of knew what was driving some ependymomas, but not all. We still had about 3/4 of ependymoma cases where these fusions were not found. And it wasn't until about 10 years ago when this new test came into the field more, which is called methylation classification, which is a technology now more and more used in many centers around the world, that allows us to classify ependymomas more and more. And you could say, well, what is that? Is that useful? Do we really need to know that? And my answer to that is yes, absolutely. Even though we might not know all the answers to all the questions we have, but classification and giving the tumors a name is the first step in understanding where they come from, what they need to thrive, and how we can block that for our best treatments going forward. So methylation classification, in addition to all the testing that we've already heard about, is really now, I would say, the standard of care, and also as such is described in the WHO classification. And who does that, or who should talk to you about that? Like we've also heard before, you need a quarterback. Ependymoma in your team, I mean. Ependymoma is a very long journey, as many of you know, and it always needs different kinds of doctors helping you. A neurosurgeon, a radiation oncologist, an oncologist, neurologists, pathologists, all these doctors. And in the most ideal case, they should all work together in what we call multidisciplinary tumor board, which we had heard about earlier. Because in those tumor boards, what happens is that doctors meet, talk about all the patients they have seen in the prior week, and discuss all these different aspects. They discuss about the surgery. Was it enough? Do we need to go back and do a second look surgery that we've talked about? And again, what is the diagnosis on the methylation side? What are the biomarkers, the most precise biomarkers that let us give this ependymoma, the specific in this patient's ependymoma, a name? And oftentimes in our case in Boston, but in many places around the nation and the world, it's the neuro-oncologist who then summarizes all this information that is discussed at tumor board with the patient, a primary oncologist ideally, but sometimes can also be the neurosurgeon who is your quarterback in that sense. Coming back to the importance, why is it important? We currently use the methylation classification, or the methylation subclassification, as a marker for diagnosis, and we're starting to use it for prognosis. sometimes or oftentimes I get asked by my patients, Dr. Filbin, now you gave me all these complicated words, but what does it really mean? And unfortunately, oftentimes I have to say, we don't know yet, but we still need to know, because the more patients we see with that particular name or that particular fusion, the more we can find what's similar among those patients. And then the more we learn as a community, the more we can design clinical trials specific to a particular tumor subtype, and then move the field forward together. So while right now these complicated names and subclasses with all fancy names don't have a particular treatment linked to them quite yet, we're really starting to do just that. And there's a lot of clinical trial consortia around the world, especially for pediatrics, but I also know for adults, that are now starting to take that into account, looking at exactly the subtype. And in order to enroll onto such a clinical trial, you will have to know. So again, even though the importance right now is diagnosis and prognosis more than anything, in the future, it will be clinical trials based on that name of your tumor. And just to give you 2 examples and also go a little bit into what Daniel had just mentioned, Zephyr-Relay tumors are a subtype of supratentorial ependymomas. So that's a mouthful. Just to say that it's an ependymoma in the upper part of your brain, supratentorial, and it's driven by fusions called Zephyr-Relay. These fusions were first diagnosed 10 years ago, or first found 10 years ago, but the Zephyr part has just been described in 2021. Just to give you an idea how quickly this field is moving, even though I'm aware that for a patient, for a family, it couldn't move, fast enough. And like why this hasn't led to treatments quite yet is a good question that I always get asked, but we're working on it. And in particular for this subgroup that was just described 3 years ago, there's a lot of worldwide collaborations that are going on that many of us on this call probably are also part of, where we share patient samples so that we have this good number of patients with the same exact diagnosis that we can then look in further detail. And then again, looking at what drives these tumors and how can we start to treat. And some of these papers will be coming out soon, later this year probably, or maybe early next year, and will hopefully form the basis for our next clinical trials. And just coming back to what Daniel said as a last closing remark, diet and different ways of treating, in addition to what we thought of conventional chemotherapy is, which is toxic, is also becoming a big part, especially of the ependymoma community of research, at least for now, because we are learning and starting to understand that some ependymomas are driven by different metabolites. That means something in either your diet or in the part of the brain where the tumor grows is particularly different in certain tumor subtypes, and then we can revert that therapeutically. So far, not quite in clinical trials, but it's really important that you tell your doctor about what supplements you're taking, what other things you're doing, because again, we are starting to understand that metabolism has a huge impact and importance in ependymoma. So the more we share and the more we learn together, the faster we will move the field. So just rounding up, thank you again, everyone, for being here today, for sharing your stories, for coming. We will only move the field forward if we work together. And it's really, really wonderful to see you all here.